wanted to talk to everyone today about our newest program in the Health Sciences Division, which is Medical Laboratory Technology. And I want to talk a little bit about what actually medical laboratory technology is. And the reason why I decided to do that was that I'm finding out in my travels and talking to people that are interested in the field that nobody really knows what medical laboratory technology is, which is a little bit surprising because it's been around for about 45 years now. And the reason why a lot of people don't hear about medical laboratory technology is because even though you're going to find a medical lab in every hospital in the United States, these are people that typically do not work with patients. So if you're an average patient in the hospital, you're probably not going to encounter a medical lab technologist unless they come into your room and draw your blood. So medical laboratory technology is kind of a field that I stumbled into. I was actually got my start many years ago in community college and wasn't really sure what I wanted to do, and started taking courses and found out that I got to take a couple of medical lab courses because they sounded interesting. The professor of one of the courses said, well, did you ever consider a field in medical laboratory technology? And I said, what is that? I don't know what it is. And so after he explained it to me, then I thought, wow, that sounds really neat. I think it sounds like something I would like to get into. And this is an interesting field because it's kind of a melding of health sciences with the actual sciences themselves. And these are the people that are really going to play a role in the diagnostic process for the physician. So we play a very centralized role, even though the patients typically don't see us on a day-to-day basis. But our role in the hospital is equally important as any of the other health profession roles that you find. So I wanted to talk a little bit about medical laboratory technology and what it is, and then I want to talk a little bit about our program and what we're going to try to be offering here at Virginia Western. So first of all, what is Med Lab Tech? Well, what we're doing is we're analyzing blood. For the most part, we're analyzing body fluids, occasionally tissue samples, and what we're doing is we're using that blood and body fluids and tissue samples to try to help the doctor to diagnose different diseases. And I'm sure most people in their lifetime and experiences with the doctor's offices and the clinics that they've gone to and hospitals, they probably had blood drawn more than one time in their life. And a lot of people wonder what happens to that blood, and specifically, why is the doctor drawing my blood, and why do they need to draw so much blood? And the answer is that the physician is trying to use that blood and those body fluids to try to diagnose what they think might be your underlying clinical problem. So for instance, you walk into the hospital, you feel very tired, you feel like you just have no energy, you are pale, you're weak, and the doctor's going to take a look at you and they're going to think, wow, I think, you might have anemia. So let's do some blood work. That's the one thing the doctor always says, let's do some blood work. So the doctor draws several tubes of blood from you. One of those tubes of blood is going to go to the hematology lab. And hematology lab is going to do what we call a complete blood count. They're actually going to count the number of blood cells that you have. If they find out that those blood cells are not within the normal limits of an average person, then that could lead the doctor to say, okay, I think you really do have anemia. Let's get a treatment course going here. So this is one of the many things that the medical lab can be used for to diagnose these suspected patient diseases. The other thing that the medical lab does, if you've ever had an experience going to the Red Cross or Virginia Blood Services here in Virginia, and you donate a unit of blood, and a lot of people that donate blood obviously knows that blood is going to go to a patient to be used for a trauma victim or people that have anemia or other problems that need to be corrected by transfusion. So we collect that unit of blood in the Red Cross and we then send it to the hospital. The hospital just doesn't simply give out that unit of blood to a patient without doing anything with it. The hospital has to be required to go through a very extensive, complicated process of screening that blood and making sure that it's compatible with the patient that they're going to give it to. And more often than not, it is not compatible, which a lot of people don't realize. And if it's not compatible, you have a problem on your hands because now you've got a patient that needs blood and you are not allowed to give that blood or that patient blood until you are absolutely sure that it's going to be compatible. And this is the blood bank part of the lab, or what we call transfusion medicine. This is one of the lab areas where you actually have a patient's life in your hands. So we are dealing with patients' lives. It is very, very possible to hurt a patient or to potentially kill a patient if you give them the wrong blood product. The other thing that we do in the clinical lab is typically we identify parasitic and bacterial diseases and viral diseases. This is the clinical microbiology lab, and every hospital has a clinical microbiology lab. So if you walk in again to the emergency room, you have a very, very severe headache and a stiff neck, your doctor might suspect that you might have meningitis, so the doctor's going to do a spinal tap, collect some spinal fluid from you. They're going to send it to the microbiology lab. The lab is then going to, try to determine if there is bacteria in that spinal fluid. And spinal fluid has to be absolutely sterile. It should be sterile. If you find bacteria in the spinal fluid, as I tell my students, that's a very, very bad thing. So that will lead the physician again to think, okay, my patient does have meningitis. Let's get this person on a course of treatment right away, because meningitis can kill within a relatively short time if it's not treated. Today, Ebola, of course, is in the news. Everyone's concerned about Ebola, and it is a major concern. Ebola is a virus, and we are getting more and more viral infections. Ebola is just one of the tip of the iceberg of viruses out there. We've had MRSA, methicillin-resistant Staph aureus that we've been dealing with for several years. All these viruses, bacteria, are very, very potentially extremely problematic for the patient. And the big problem that we're looking at in the 21st century is now we are looking at drug-resistant bacteria. And that is a huge problem. And part of that problem was caused because antibiotics have been overused for many, many, many years. And now we're paying the piper, unfortunately, and we're having to deal with these strains of bacteria like MRSA that are now resistant to any drugs. And if you have one of these resistant strains of bacteria, it is going to be very, very life-threatening for the patient. So the next big medical scare is already here, and it's going to get worse. So what are some of the functions of the medical lab historically, and what are we going to be doing in the future? Historically, as I said, we've used blood products. We've used whole blood, we've used blood plasma, and we've analyzed that blood plasma for different sorts of concentrations of different types of enzymes, for instance, in the human body, and then using those enzymes, we can diagnose a disease. Today, the field is being driven into the realm of molecular biology, and now we're starting to become very, very molecular biology oriented. And the new word, the new buzzword is genetic engineering today. And you can't go anywhere without hearing about molecular biology and gene therapy today. This is again, the 21st century of the lab. So now the lab is going in the direction of the biotechnology field. And I think in the near future, in the course of maybe 10 to 15 years, these traditional medical labs that we've had pretty much doing things the same way for the past 45 years are now going to be a very different world, where now physicians are going to be looking at specific genes, and they're going to be using those specific genes to be able to diagnose specific diseases and conditions. So it's a very exciting field, and I think we're on the tip of something very big. But the medical technology programs are going to have to change to accommodate this new direction. So to tell you a little bit about what the field of med lab tech is divided into, there's actually 4 major labs that are found in any hospital. And one of these labs is a clinical hematology lab. This is looking at whole blood. And again, what we're trying to do is help the doctor try to diagnose conditions like anemias, leukemias are probably the 2 most common conditions that will be diagnosed in hematology. The other thing that we're going to be doing is looking at coagulation. We're going to be looking at blood clotting. Many, many, many patients out there have a blood clotting problem, which is serious, because if you do have this blood clotting problem, then you run the risk of having a stroke, you run the risk of having a heart attack, so your doctor has to put you on blood thinners. Part of what we do is also monitor that blood coagulation therapy. So hematology is mostly looking at diseases of the blood and looking at blood coagulation. This is a common hematology lab that you would find in a hospital. And one thing you should notice here is that we are very extensively automated. And the big black machine that you see in the middle there is a cell counter. And that's the instrument that does the complete blood counts and the white blood cell counts and the red blood cell counts and the platelet counts. And now the instruments are so sophisticated that they even do a complete differential count where it actually tells you the difference between the different types of white blood cells. And so the instrumentation has really come by leaps and bounds over the past 30 to 35 years. So we are very heavily automated. So you not only have to know a little bit about the science field, but you have to know a little bit about computers too. And because all this instrumentation is of course computer based. Clinical chemistry is the other area that people work in. Clinical chemistry is probably the most automated area of all of the areas in the laboratory. In the past, when I started in the field, way back in the day, as the kids say, clinical chemistry was only partially automated, but today it is almost fully automated. And that was kind of driven by the sheer number of tests that these hospitals are doing. It's not unusual for a good clinical chemistry lab in a place like Roanoke Memorial Hospital to see maybe 200 to 300 specimens every day, and that might be a fairly light day. So what the clinical chemist is going to do is they're going to look at blood plasma specifically, and they're going to try to look at the content of ions and hormones and enzymes and certain biochemicals in the blood plasma. And what this is going to do is it's going to give the physician an idea of what potential disease the patient may have. Again, we have these so-called markers in the body that are going to be diagnostic of certain diseases. So again, to give you a real life example, somebody walks into the emergency room, they're having very severe chest pains. So the doctor takes a look at them and the doctor says, well, I think you're having a heart attack, so let's verify that. And of course, besides doing the EKG, they're going to draw some blood from this patient. If they send that blood to the clinical chemistry lab, the clinical chemistry lab can look at something called troponin, which is a component of heart muscle or cardiac muscle. And if troponin levels are highly elevated, that is definitely going to tell the doctor that their patient has had a heart attack indeed. And so, again, it's a diagnostic procedure. People are going to have their ions in their blood looked at all the time. Sodium, potassium, chlorine, for instance, are the three top ions. Everyone that goes to the hospital or doctor's office has these ions monitored every single day, often several times a day, because these are critical. They have to fall within a normal range. If they fall outside that normal range, it is very, very bad news for the patient. And again, it could be something which could be indeed life-threatening to the patient. So doctors have a need to monitor these ions all the time. And it's probably the most commonly ordered in the medical laboratory today. Hormone, a lot of people have endocrine imbalances. If you go to the doctor again and you find out that your metabolism is not what it should be, for example, if you're eating lots of food and you're not gaining weight, in fact you're losing weight, then the doctor might suspect you might have a thyroid disease. So the doctor will order a thyroid panel, which is very commonly ordered in clinical chemistry. And again, if those thyroid hormones are not within the range of what they should be, then they're going to obviously follow a course of treatment to try to make you well again. So that's essentially what clinical chemistry does, is we try to help the doctor diagnose these diseases by looking at biochemical parameters within the body. And this is a clinical chemistry lab, as I said, very heavily automated. As you can see here, this is our big, huge clinical chemistry analyzer. These things have come an incredible distance from when I started working over 30 years ago. Back in those days, it was much smaller and much more compact and could only do a limited number of tests. These can typically do anywhere from 100 to 200 tests, and the throughput now is something like maybe 100 tests in every 15 minutes or so. So it's an incredibly fast instrument, lots of samples, and again, this is demanded by the workload that is placed on these people. Doctors are ordering these tests all the time, and not just the hospital doctors, but all the physician's office doctors in the valley too. So we have to be very, very automated just because of the sheer number of samples that we have to deal with on a day-to-day basis. So again, very computer oriented. Back in my day, when I started out in the field, we did a lot of things by hand, and we actually set up test tubes, believe it or not. And I can still vividly remember setting up racks of test tubes and pipetting things by hand and waiting for the result to happen. And oftentimes it took 20 minutes, 30 minutes, 40 minutes to do a test, which today would be unheard of. It would be laughable, and doctors would not even accept it today. Doctors want a very quick turnaround. They want to know an answer right now. They don't want to wait 20 or 30 minutes, but back in the day, this is what we had. So again, the technology has really come by leaps and bounds. The blood bank is also called immunohematology, and we call it immunohematology because it's based on immunology, and it's based on the fact that blood can act as an antigen. And the fact that people don't have different blood types is a huge problem, because if I'm a type A person and you're a type B person and you try to give me your blood, I am going to have a very violent and perhaps fatal transfusion reaction, because there's an antigen-antibody reaction between your donated blood and my blood, and this is the basis of blood bank. So blood bank is out there to try to find compatible blood, and this is what we have to do. And again, we just can't hand out a unit of blood to a doctor and say, okay, here it is, go for it. You have to cross-match every unit of blood that you have. You have to type and do an antibody screen on every patient that you have. And oftentimes, these patients that come into the blood bank develop what we call atypical antibodies, which are antibodies that arise out of nowhere because they've been transfused before. And if this is the case, these people are highly problematic, because it gets to the point where it can be extremely difficult, if not impossible, to find compatible blood for these people. So the job of a blood banker is probably the most stressful, because you're under the gun every day. You have a time limit that you have to get this blood out. Of course, if it's an emergency, the doctor is there screaming for the blood, and they don't understand that you have to work up this blood and make sure that you have compatible blood. So this is probably the most stressful part of all the labs that we currently can work in the hospital. Today, more and more patients are demanding specialized blood products. So now we actually wash blood, believe it or not. People find the concept of washing blood to be a funny concept, but we actually take blood that we collect from a person and we put it in what we used to call a washing machine. And we would actually remove all traces of serum from that blood and replace it with saline and repack the blood cells in saline. And that's what we would transfuse. And for certain patients, especially pediatric patients, this is a preferred unit of blood. Also, for pediatric patients, a lot of physicians have to require that their patient have their blood irradiated, and this is going to prevent certain immunological diseases. So blood bank is a much more complex lab than a lot of people really think it is. And it's one of the last labs to be automated, because you really want to have a human being there doing all these testing. You don't want to give all this work over to an instrument, because that's going to potentially lead to mistakes. There's nothing that is going to take the place of an actual human being sitting there. So blood bank is still kind of the last holdout of the automated labs. But now, like anything else, it's starting to be automated. This is a unit of blood that they would typically draw from you if you went to the Red Cross. And this is what we call packed red blood cells. It's the most commonly transfused unit of blood. And this is showing you the antigen-antibody reaction. So if you have clumping, as you can see there, that is what makes the blood not compatible. If you don't have clumping, the blood is compatible. So this is typically what you're going to see in a blood bank. Clinical microbiology or clinical bacteriology is the other lab that we have. And of course, this has always been a huge lab, and it's not just bacteria. It's bacteria, it's viruses, and it's parasites. And we are faced with all three of these as potential disease-causing agents. The problem with bacteriology, and there's always been the problem, is the fact that every one of us lives with normal bacteria that are supposed to be with us. So if somebody comes into the doctor's office with a bacterial infection, it is pretty darn hard to try to diagnose that bacterial infection because the patient has so much of this regular bacteria that live with us. So the job of the microbiologist is try to find the abnormal. And oftentimes it's like trying to find a needle in a haystack. So for example, Streptococcus pyogenes, probably people don't know what Streptococcus pyogenes is, but that's the causative agent of strep throat. But it's hard to find Streptococcus pyogenes because we have millions of bacteria in the throat that normally live with us that look just like strep pyogenes. Of course, virology, as I said, is getting more and more important. Now we've got SARS, which is a severe acute respiratory disease that was endemic in China a couple years ago, and luckily enough, it did not hit the United States. We now have Ebola, which is coming to the United States and is already here. We've got other diseases that are potentially going to be problems too. So virology is another big field, and we have people that are dedicated to just identifying these viruses. And these people work closely with the CDC or the Center for Disease Control. If we find that we do have an appearance of Ebola, for example, in Roanoke Memorial, you better believe that the CDC is going to be informed of that, and they need to take some action and make sure that Ebola is not going to spread like wildfire through the Roanoke Valley. These are the plates that we use to culture bacteria, and what you're looking at the top left corner there is a plate which shows you the bacteria that causes strep throat. And that little disc on the plate is actually an antibiotic soaked disc, and you can see that the bacteria are not growing around the antibiotic soaked disc. And this is actually going to tell the people working in the lab that this is indeed strep throat. The plate is red because it contains sheep blood, and the sheep blood is going to hemolyze because of the bacteria. And the fact that you do see that discoloration there, that is also going to tell the bacteriologist that this is indeed what is going to cause strep throat. And another close-up of that same plate down there. The plate at the upper right-hand corner is an antibiotic plate, what we call a Kirby-Bauer plate. And this is showing you how different antibiotics are going to react with different bacteria. And of course, you notice that the bacteria are not growing around each of the little white discs. Each of the little white discs contains a different antibiotic. And you can see, just from looking at this, a physician can see which are the good antibiotics and which are the ones that are not going to work. Obviously, the good antibiotics are going to lead you with the biggest circles. The ones that don't work are going to be the one in the upper right-hand corner that allow the growth of bacteria. So this is how we used to do antibiotic testing in the old days, and of course today this is also automated. This is how we automate microbiology today. This is called the VITEC instrument. It not only identifies bacteria for you, but it also does all the antibiotic sensitivity testing. And now we have a brand new era that's just dawning. We have VITEC instruments that are now being replaced by actual mass spectroscopy instruments. And these mass spec instruments are now going to be able to identify bacteria, but they are extremely expensive, probably $50,000 to $100,000 for a good unit. But Roanoke Memorial is going to have one in the next couple of years. And this is just an example of what Ebola looks like. That is the Ebola virus if you've never seen it before. And as I said, this is getting to be quite a problem. The picture on the left, those are red blood cells. And inside those red blood cells, those little discs that you see are actually malaria. And that is malaria growing inside of the red blood cells. And this is diagnostic of malaria. So if you see this in the lab under a microscope, you can go back to the physician and say, yes, your patient does have malaria. Urinalysis is part of clinical chemistry, and yes, we do look at people's urines, and yes, it is a major part of the laboratory. And a lot of people have walked into their doctor's office and you've had to give that little specimen in the cup. And this is what urinalysis is. This is what urine looks like under the microscope. This is particularly nasty urine because it's got a lot of things in there that should not be there. It's got bacteria in there, which are those little rod-like organisms. They should not be in urine. It's got white blood cells in there, those round cells, which should not be in urine. But if a physician were to look at this, they would say, yes, this patient has a urinary tract infection. It's as clear as day. So this is again, very diagnostic. The other thing that we use urinalysis for is to look for things like blood or urine glucose. If you have glucose in your urine, it means that you're diabetic. If you have protein in your urine, that means that you have kidney failure. So again, very, very specifically diagnostic. There's a reason why the doctor wants that little cup of urine. And of course, we now do drug testing. All the jobs that you get are going to collect urine, and we can actually find metabolites of drugs in the urine, which is going to tell the person whether you've been taking illegal drugs or not. The next phase of the clinical lab, as I said, is going to the molecular diagnostics field. And now doctors are going to start to look at groups of genes. Instead of looking at individual biochemicals, we're going to look at genes and what we call gene arrays. This is batteries of genes. And by looking at these batteries of genes, now doctors are going to be able to specifically diagnose different conditions. This did not become very popular until the late 1990s, so it's relatively new technology. And the reason why it waited that long is because we didn't have the computer technology until about the year 2000. And so now we do these very complicated tests like gene arrays, where we can actually look at hundreds of genes at one time through a very sophisticated computer-based system. And again, this was something that we could never do before the year 2000. And this is something which is now very, very popular, not only in the clinical lab, but in a research lab setting. And again, very complicated biotechnology, molecular biology techniques that we use for this. So what the doctors can do with this now is we know that there's certain genes associated, for example, with different types of cancers. And if you look here in the middle of this chart, you can see the BRCA1 and the BRCA2 gene. I bring that up because that's been in the news. It's what we call the BRCA gene. And if you've been following the news, you might have been following the case of Angelina Jolie, who's been going through this surgery to try to remove organs before they become cancerous. And that is because she is positive for the BRCA gene. And if you are positive for the BRCA gene, there's a very, very high probability that you're going to end up with breast cancer or uterine cervical cancer or ovarian cancer, which is deadly. So now people are starting to be proactive about this. They'll go to the doctor will tell them they're positive for BRCA, and they can decide to elect to undergo the surgery that will prevent them from getting that cancer. And you can see that every type of cancer has its own genes associated with it. So what we are intending to do with our program is an associate's degree program, Associates in Applied Science. It's a 2-year program, and it's going to have 1 semester of clinicals associated with that, so it's a 5-semester program. And at the end of this time, you're going to be certified as a medical lab technician. There's 2 levels of worker in the medical lab. There's a 2-year medical lab technician and a 4-year medical technologist, which today is now called the medical laboratory scientist, or MLS. So we are going to allow people the option of getting the MLT degree, and then they can either go to work right away as an MLT and start working in a hospital lab, or they can elect to transfer to a 4-year school. We're going to be talking to Jefferson College here. In fact, we already have. We're going to be talking to Radford about transfer programs from our school into their MLS program so that they can graduate after they do a year or 2 years at Radford and then come out with their MLS degree. And the requirements of the hospital are that you have to have an MLS degree if you want to be a lab supervisor. MLTs are not allowed to be lab supervisors, but they can do virtually everything else that an MLS can. Of course, the salary of an MLT is lower, which is, again, the reason why we are starting our program, because hospitals, being the money-making organizations that they are now looking to hire people at a lower salary level. So now there is a drive to hire MLT people that's out there, because they can pay an MLT person less money to essentially do the same job that an MLS can do. So that's what we're going to try to do. And in order to work this piece of molecular biology into it, we're also partnering with the STEM division, and we're getting together with Amy White and Stacy Devers in the STEM division, and they are working up a biotechnology program, something that we've never had in the STEM division before. And I'm hoping that my people going through my associate's degree program can go through this biotechnology program in STEM. This is a career studies certificate. It's a matter of taking, I believe, 4 courses, and they will have the career studies certificate in biotechnology. And I believe that it will really help them in the future when they go out and they try to find jobs in the field, because as I said, this field is becoming molecular biology. So I think this is an excellent opportunity for the people that are in science, that might be interested in working in science field and in working in healthcare. And for me, it was a perfect field because I was in a hospital. I was helping patients with their diagnoses and helping patients with their treatments, and yet I didn't really have to deal on a day-to-day basis with patients, which was great for me because I was not a patient person. But this is why I think this field is wonderful for people, for example, that want to go into healthcare but really don't want quite that patient contact, or really aren't comfortable working around patients, which sometimes are not the easiest people in the world to work around. So the biotechnology people not only are going to have the ability to go and work in the medical lab of the future, but they also have the ability to go off on their own. And if they want to, they can work in one of the biotechnology labs that are starting to spring up in the area. So for example, we have Novozymes over in Salem. We have several other labs that are now starting to spring up. So there's a huge call for biotechnologists in the Roanoke area right now. So I will say that if you want more information about the field, you can always come and see me. I'm Jeffrey Gillette. I'm over in the Fralin building on the 2nd floor on what we affectionately call Skid Row over there. I'm near the radiology people. And if you want more information about biotechnology, you can certainly see either Amy White or Stacy Deaver, who's in the STEM division, and they are up on the 3rd floor of Fralin also.